A very warm welcome to you all to this afternoon's fireside chat. Yes, for those of you joining internationally and unfamiliar with the British climate, it is absolutely possible to have a fireside chat in June. Today's event is the second in the Global Innovation Forum's free What's Next webinar series. That's hashtag What's Next, which is about tapping into the knowledge of our community and focusing on opportunities for positive change during the current pandemic. Many of you will already be familiar with the Global Innovation Forum, an innovation journey that began for Max and the organising team from Selectiva 10 years ago this year. Initially a pilot conference event, it really has grown far beyond the boundaries of an event into a community of like-minded innovators, many from different backgrounds, different industries, market sectors, united by a common challenge of sharing inspirational perspectives, cross-fertilizing ideas and experiences to solve human challenges and make the world a better place. My name is Ben Strutt. I am Director of Design and Front-End Innovation at Cambridge Design Partnership. We're a global insights, research, design and technology development partner working both on consumer and new healthcare devices and technologies with offices in Cambridge, UK and Raleigh, North Carolina on the US East Coast. Before I introduce today's inspirational guest, I am pleased to confirm that we will also be joined live by Josh, an illustrator from company Live Illustration, who, as the name suggests, will be sketching our conversation in real time. Josh and his colleague Chris are both staples of the annual conference, producing an illustrated record of the two-day event that regularly covers more than 10 square meters of paper. I will be video spotlighting his progress from time to time through the conversation. As we are all painfully aware, we are living in a time of unprecedented change, and history shows that periods like this often witness significant technology and behavioural shift compressed into very short spaces of time. It is therefore an absolute privilege to be hosting someone who has been working in the future for quite some time. Today's webinar guest, Professor Shafi Ahmed. Many of you will already be familiar with some of Shafi's pioneering work, but for those who aren't, Professor Ahmed is a multi-award-winning cancer surgeon working at the Royal London Hospital. He is a member of the NHS Assembly advising the government on the NHS Long Term Plan and was awarded the Future NHS Award by Members of Parliament in 2018. He has been given the accolade of the most watched surgeon in history. As we're about to find out, he has moved his professional interest beyond surgery to work as a futurist, an entrepreneur, an innovator, bridging science fiction, education and medicine. Shafi, good afternoon.
Good afternoon, Ben, and thanks so much for the kind introduction. Great to be here at this global conference.
Oh, I'm delighted to have the chance to talk to you. I mean, these last few months have seen so many people engaging with digital and virtual technologies like never before. Here we are. But actually, you're probably one of a small group of pioneers for whom daily virtual working actually isn't a new thing. This accolade of the most watched surgeon in human history really sets the scene. But for anyone who's less familiar with your pioneering work in immersive and augmented reality, I wonder if you could take us all back in time and tell us the story of how this reference actually came about.
Sure. I'm not sure that accolade is correct, but hey, people offer those accolades, you take them where you can. So I guess if you go back, I'm a practicing surgeon, I'm a cancer specialist working out of London, and I specialise in colorectal cancer, and I'm a keyhole surgeon. That gives you kind of the background of my clinical experience, but also I was Associate Dean of the medical school at Bart's Medical School, one of the oldest medical schools in the UK, teaching and training people for a long period of time. And also I was a national trainer for surgeon training. So all that combined made me a surgeon who's thinking about education training, involved at undergrad and postgrad level, thinking about what is that future look like. And I was really trying to disrupt and change the way education is brought to people. Two things came to mind. I did a lot of global health work, as you know, Ben. I travel a lot to many countries. And I think, well, how do we overcome the barriers of education around the world? How do we use our knowledge and spread it on a global level effortlessly? And that meant really by way of connectivity. That's kind of my kind of story around connecting people, being virtual, being remote. How do you bring that global community together? So let's go back a few years in 2014. Now, you remember the Google Glass that came out, Ben? The infamous, I would call it Google Glass, which had a terrible reputation because it didn't have the right use cases and people didn't, it wasn't too early for its time. But it was a fabulous device. It was a wearable device, for those that don't know. You could perch on your head. It became a mobile phone in essence. You could talk to it, voice activate it, and video record, etc. through your points of view. And I thought, what great idea to teach surgery. So surgery in the past, remember, is taught in the operating theatre. 4, 5, 6 students may be there together at any one point in time. They're not really engaged. They're on the back of the room on their smartphones, on social media. It's not good active learning. It's passive learning at best. And actually, to spend that much money to be taught in that manner seems to be a lot of larger waste of time.
It's interesting you say that, because I've done theatre observations, and actually a lot of what you see is the kind of back of the lead surgeon's head.
And that's all that you see. And although you become very good at counting the hairs back of someone's head, you don't actually learn much in ways of anatomy or surgery. And it's just the way we are. So I thought, let's do it differently. So I got the Google Glass, got my team to reconfigure it so that we could stream live an operation, which I performed as a cancer surgery, and we pushed it globally. On that day, I taught 15,000 people across the globe in 118 countries, showing that just with a simple smartphone connectivity, they could view live through my eyes, and also they could put a text message onto their smartphone or iPad or computer, which would come up in my glass in the corner as I was operating. So I'd interact at the same time and teach on a global level. But then push that to the next level. So, okay, that's kind of being remote, that's telemedicine, that's great. What about if you could bring people into your operating theatre? And obviously virtual reality was coming out, and we were experimenting with 360 cameras and live streaming. And I did the world's first VR operation in 2016, where I transmitted a live cancer operation across the globe. And that was watched by 55,000 people simultaneously, almost using Google Cardboard headsets and other headsets. So they can literally, for the cost of a Google Cardboard, which is $4 or $5, a smartphone free app, suddenly they could engage and actually be in the operating theatre from anywhere in the world. And we reached out to about 140 countries on that particular occasion. Then when I moved it on, I said, okay, that's great. And we're doing a lot of work on immersive tech. What about using social media as platforms? So I did world's first operation on Twitter, pushing out on tweets, saying, let's connect with people who are on Twitter. Facebook Live, when it came out, pushed a live operation to people in Bangladesh where I was working, doing some humanitarian work. And that was watched by 10,000 people, literally on a smartphone. But I thought, okay, let's push it even further. My trainees and students are really young. And I vaguely understood Snapchat. I heard about this concept, this social media platform. I'm too old really for it. But hey, I thought, but actually, if you look at the users of Snapchat, out of the 200 million users worldwide, 70% are between the ages of 17 and 25, which is that age that you want to be connected with, because they are the age of your students. So I pushed out a live operation using Snapchat spectacles, which come out, recording small clips, bite-sized information, enough for people to be interested, onto my story live, which really was, I really was unsure how that would be taken by wider society. But anyway, we did it. Needn't have worried. Over 2.5 million people watched the operation live throughout the world within the next month or so. It was shared widely, and it was kind of a good use case story of social media. And it kind of, I think, lit the fire of social media education. So we're looking at the way of connecting people, Ben, and the story around is, my story's always been, how do you connect people's minds? The way we're going to shape the world in the future to empower people further is to connect people through their minds. So, I gave a talk around connecting a billion minds as my TED talk. But actually, you can reach further than you think you can just by connecting people, smartphones, simple technology in some sense that's cost effective, and share knowledge on a wider scale. And that disruption being virtual, we're now seeing today being accelerated by the pandemic. So that's a story around the operations. And the last thing I did, of course, we did a live operation on Channel 5, called Operation Live, which you can still watch it on My5 Live if you want to. Live operation on main channels to the public, pushing the boundary. What would they like?
And you did that actually about a week after we first met back in 2018, I remember. And one of the things that, having been in theatre, is I've noticed that sort of transition from, I guess, more traditional major abdominal incisions through to laparoscopic techniques. You were using a range of bits of kit, a harmonic scalpel, and so on in that theatre. Again, many of the viewers will be familiar with surgical techniques and equipment, but again, for those who aren't, maybe you could just talk a little bit about those advances, and particularly why, for example, laparoscopy is a benefit in terms of patient outcomes and minimally invasive procedures.
Of course. We're very thankful for people like you, Ben, who are at the forefront of designing what we need to do in the future, giving us the necessary tools, if you like, to practice our surgery. So if you go back about 20 years ago, when I was beginning to train fresh from medical school, we were doing more open surgery, which means you're using a big scalpel and a blade, and using techniques that probably now rather prehistoric. So the laparoscopy came out where you can now use a simple camera into, for me as an abdominal surgeon, to insert the tube and camera through the belly button, have a look here with good definition cameras with the necessary equipment that was then developed to be able to do major surgery. And that, of course, was developed by the gynecologists many, many years ago. Surgeons and general surgeons only got hand of it really in the 80s. And then 90s, where they started experimenting. Now we come to stage now that basic laparoscopy is the gold standard for all operations. That's our first point of contact because it has several advantages. It offers the patient less pain, smaller scars, etc. Cosmetically, it's obviously better. The recovery is much quicker. And the outcome is better. So now it allowed us to do these operations where patients can go on the same day now, for example, which they couldn't do before. So it's reduced the time taken in hospital beds, makes things more efficient, less pain. It's become more cost effective now. It wasn't at the beginning as you drive change. Now it's become, and that's the de facto gold standard around the world. Having said that, of course, around the world, it's not available to everybody. You know, we talk about the global health situation. A lot of people won't have access to laparoscopy or the equipment that can be expensive in the beginning. So yes, there's still a kind of disparity of healthcare. And we'll talk about the future, of course, where we go from laparoscopy, that future, I'm sure we'll discuss soon, around robotics and the future of how we're going to use more technology to make the surgical operation even more precise and data-driven.
Well, you hinted at the sort of march of technologies, which is initially cutting edge and used by a niche, and now you said laparoscopy is kind of the mainstream now. And of course now, as you mentioned, we're seeing surgical robotics starting to come into theatres. You know, sort of the battle for robotic operating theatre supremacy. Companies like Titan Medical that we're working with, pioneering these extraordinary ways of delivering very complex access, minimally invasive surgeries. Again, you know, looking at that future step change in surgical technique, what are robots now bringing in that wasn't possible, or what's the added advantage of those through your eyes?
That's a really good question, actually, and I think it's yet to be discovered, actually, at the outset. So let me tell you about robots. So we discussed it the other day, and I predicted that 2020 would what we call the robot wars, okay, realistically, because obviously before that, there's one company that had the kind of the entire market, which was Intuitive Surgical with Da Vinci, which is an amazing robot, don't get me wrong, amazing technology that's driven over 20 years. Now it's all changed. We've got a plethora of robot companies coming to market. Robots becoming smaller, more sophisticated, more, I guess, based around data. There's some augmented virtual reality within the framework as well. They're sort of more sophisticated and getting better. That's what that would do for us. It reduced the price of the surgery. At the moment, it's quite expensive and not really, doesn't allow surgery to become democratized. They're now using more analytics around that, bring data through that. For example, so the future robot for me would be one that's connected. We talk about the connecting 5G, whatever it is. You could be remote, for example. You could be on the console. You could then actually do the operation where there's visual display coming up in augmented reality using AI, showing what structures are around, what's the next steps of the operation, predicting safety, and storing more information so you can go back and say how you performed as a surgeon. It was amazing. We never had objective data on our performance. There'd be food measurements on mortality, on complications, but interoperatively, there's very few, there's very little evidence of how you're performing. So imagine that, suddenly you could be assessed better and actually make improvements as you go along. So as is before, the robots are going to be allowing us to do more precise surgery in small areas within the abdominal or thoracic cavity or in the brain. It'd be much more precise, takes away the human error and the shake, for example, and the visualizations, of course, much better. And of course, the analytics and the AI system will power for you to be much safer, etc. That's both during the operation, before the operation. You can plan things better. So the whole world is looking really exciting. The problem, of course, is that at the moment we can't prove it's better than laparoscopy because it's the same thing, essentially, Ben. So all we're proving is laparoscopy is the same as robots. Robots can do the same operation, yeah. But
and the analogy you're drawing there is through single port or a small number of port access.
Yeah, that's the same concept. It's the same kind of operation. It hasn't changed the actual operation itself. Yeah. It's made it different and more, I guess, better for surgeons, ergonomics and visualization, etc. It's hard to prove any increased outcome. So what will happen as the cost comes down and it becomes the same price laparoscopy, suddenly it'll accelerate because there's no capital expenditure required for anybody to start working on it, and they can show it's cost effective. And of course, that's always a cycle of technology innovation, but as you know, and we're in that cycle at the moment, and it's exciting.
It's interesting you touch on ergonomics as designer. One of the things I noticed was that actually, because you've then got the display that's separate, suddenly the surgeon, rather than being in this very sort of crouched over position, is actually sat in a more relaxed position, looking into the monitor. And actually, I kind of wonder whether the sort of reduced fatigue, the improved sort of ergonomics of that is actually going to have a sort of secondary effect on the successful outcome of a procedure.
Well, I certainly feel that the chiropractors will probably go out of business from surgeons who've been trying to find cures for their back pain. But you're absolutely right. I mean, hunched over for many hours a day on an operation, it's really hard, actually. It does have impact on your physical ability over many hours. So imagine doing 8, 9, 10-hour operation. It's physically demanding, it's exhausting. There are times when you do get distracted. And this is where I think a robot has huge advantages. I think it will protect us longer. It'll make our lives much easier. And also I think it's more comfortable. And you guys, of course, have worked on so much of the ergonomics for us, make it easier for us to sit down a console away. And I think that's a huge benefit, which is the unintended benefit that we don't really assess, because we're assessing cost and we're assessing complication. But actually, what about the comfort of a surgeon? What about the comfort of an operation, which is hardly ever part of the equation? So I think you're changing the conversation around what a surgeon is going to do in the future.
Interesting. And I mean, we talked a bit about outcomes, patient outcomes, particularly at the moment. I mean, I think we're getting very used now in relative terms for the risk of surgery coming down and down over time. But I mean, certainly a lot of your work, as I understand it, you've taken on the most difficult cases, the most challenging cases. That risk never goes away. And there's an interesting sort of innovation metaphor there. If you're doing breakthrough innovation, the risk never goes to zero. So how do you, working in that sort of environment, try and characterize and manage and mitigate some of the risks that you're facing?
That's a really good question. So this is really the crux of being a surgeon, I guess. Part of it is, of course, experience. That you've seen things happening before, the complications, you've dealt with things, you've done major complex operating. It's about the training that you've had, and also the experience as a consultant for many years. But what you try to do is you try to predict. If you look at an algorithm, for example, let's talk about technology and the way we may innovate in the future. The algorithm is this: you assess people in clinic, for example, you're trying to quantify risk for them, given their history, their age, their comorbidity, all the things that might be relevant to a surgical operation, through an operation, through anesthesia, to recovery. And they say, okay, during the operation, you're looking at the images, you're looking at trying to work out in 3D modeling what's going to happen in the operation, how you can plan it, etc. So there's the pre-planning for the patient, risk stratification, and also, of course, at the operation, you think about risk that you're doing at the same time. Remember, as we're doing the operation, we're making choices every few seconds, every few minutes. We don't just carry on endlessly. We're constantly redesigning, rethinking, trying to avoid any major catastrophes all the time. And then we take that kind of risk-averse nature. If we're going too far, we stop. And we also wonder, and the people don't realize, we often stop during the operation. I pause. If I think it's difficult, I'm doing something that might be damaging, I pause and to have a think and step out, very much like zoom out and zoom in, as Job used to talk about. You zoom out and try to take a kind of idea about what's happening to the patient intraoperatively, the physiological markers, the anaesthetist views, and you're trying to get a view of what's going on. So we're constantly adjusting the choices we made. And this is the decision-making that's difficult to replace, because it's human decision-making, after all, about what's right for the patient, what's ethically the right decision to make. And that is going to take a long while for, say, technology to even come to somewhere near it. It's that judgment call that I think is the most toughest one for technology to try to simulate. It may never simulate. It may still be in control all the time, but have the technology to support, innovate, and augment our practices.
And picking up on that idea of the sort of judgment call, I mean, the judgment call is going to be based in many occasions, I guess, on experience, which kind of brings us quite elegantly back to this idea of education and healthcare. And I think, looking at the current situation, I guess that the pandemic, if we were to sort of call out a couple of sectors that are probably going to change the most as a result of this, it's got to be education and healthcare. And I know these are both sort of very close to your heart and probably inseparable actually to you. You openly promote this sort of personal mission of merging the world of medicine and global education and augmented reality. Can you talk a bit more about how you think these things will integrate, and then maybe after that we'll check back in with Josh and see how his sketching is going?
Of course, good idea. So look, what we've seen during the pandemic, so one thing I talk about the pandemic is really important. we've been talking about this, you and I and others, of course, for many years, wanting this kind of these exponential technologies to take place as fast as possible. And we've been limited by the barriers of adoption, the barriers to translation, and just the inertia of our healthcare systems that don't want to change, right? So we know that. So what the pandemic has done is shown that we can change quickly. I was involved in the Nightingale Hospital. I was the surgical lead for that whole hospital, and that was created within 3.5 weeks from a big deserted warehouse conference into 4,000 beds that had IIT facilities. So we can do it if we want to. We're also seeing a relaxing of regulation rules where people want to innovate and bring it into speed. Take one example for you. I always talk about doing virtual medicine, telemedicine, for example. I've been pushing that for a long while, saying that basically the face-to-face contact is too expensive. We can't afford that luxury of being face-to-face. How do we democratize even that part of it? So now telemedicine in the first 2 weeks of the pandemic went up by 1,000%. Now it's a 5,000% increase. So now the new normal, or the normal of today, is remote telemedicine. We spend our lives on Zoom, on Microsoft Teams, etc. And so the world now is just accepting this new normal. It just needed a trigger. And what I call it, Ben, is compression of time. Time's been compressed in these last 8 weeks. Time that was going to take 2, 3, 4 years into 2 months. So we're seeing now that rapid change, and we're now figuring out what that new normal might look like. And education, of course, is a key parameter. If you look at the online education, they've exploded. People looking for ways to learning. School kids have been at home. My own 2 school kids have been at home on Microsoft Teams, being taught a different way, whenever it was possible. But now they are. They're engaging in a way they haven't done before. And even universities, this is interesting. Cambridge University announced a few weeks ago, that the next year, they're going to push all their stuff online. You will know that, right? This is one of the oldest, most prestigious universities in the world saying, actually, we're going to change for 12 months to make it online. So this is a huge expansion, online, moving forward, being remote. And remember, going forward, you may not have universities in bricks and mortar. They may be virtual universities, or maybe hybrid, where you do some online, some actual face-to-face. So the education will change. The last talk about education is this. Are we training the next generation of healthcare workers that are relevant? We're not. So the problem we have is that digital learning, the digital landscape and the language of digital technology is unknown, a scary item for most healthcare workers, yet they've been forced to adopt it at pace. So we have to redesign curriculums, undergrad, postgrad, all healthcare workers need to be trained in digital transformation, the new language that's out there, so they're more comfortable to have their conversation with their patients, with their colleagues. And that needs a lot of work on. And one of the things I did, I set up the BARTS-X program at my medical school, which was a first program in the world that embedded innovation, entrepreneurship, and technology into the undergrad curriculum 3 or 4 years ago. I know this is going to be necessary. I'm sure now that it's come through, other medical schools will finally change and start thinking about that future healthcare worker.
But is it extraordinary to take an event like this to really catalyse some of those sort of cutting edge technologies? You mentioned Google Glass being ahead of its time earlier on, and now this to really elevate telemedicine to the mainstream. I'm just going to invite Josh, if he's online, to share his current illustration and maybe say a few words about what stood out for you, Josh.
Yes, hello, can you hear me?
I can indeed.
Well, so far there's almost too much for me to really take on board, but I'm really dazzled by the educational element, this idea of connectivity, that we're saving time, we're saving on resources, and we're making everybody's life a whole lot more comfortable. That's fascinating to me. The idea that the idea that robotics and technology are quantifying and helping the surgeon as you go is really inspiring.
Thank you. Brilliant. Thanks, Josh. So you mentioned being involved in the Nightingale Hospital there. I mean, you know, many of the politicians at the moment are comparing this current situation to a sort of wartime scenario. You know, I mean, the Nightingale was a prototype. It had never been done before. It was going from, you know, nothing to potentially a capacity of 4,000 beds. And I appreciate there may be some aspects that are confidential about your involvement in that. But if you feel able, you know, again, just focusing on the kind of innovation metaphors there, could you maybe share some of your insights around the challenge and the sheer logistics of planning and then execution to create something in such a short space of time? I mean, an innovation sprint, literally.
Yeah, so obviously it was born out of necessity. We knew that if the pandemic took its hold, then there wouldn't be enough ITU beds in the country to manage the ventilators and the patients that might require that ventilatory support. So obviously what happened was medical staff and healthcare workers in the NHS were fully swamped with work. The prediction was going to be rather dire. So obviously the government went to the military together with the NHS to work in collaboration to use the Excel Centre, and you will be the Excel Centre, of course, Ben, a big, massive conference hall, to redesign that very quickly to become essentially a 4,000 bedded hospital with ventilators for each patient. That was the kind of the mission. So imagine the process of that. It's the logistics of bringing all the equipment in, for example. There's stuff around building up ventilator capacity, which we didn't have at the time. There was the IT infrastructure to be put in, so it was all connected. And our own hospital, Bath South, became the kind of the support, if you like. They controlled the hospital because they had connections with pathology laboratories, imaging, etc., so that there could be a seamless way of using the electronic health record to help patients in that sense. Then, of course, it's the training the healthcare workers in a different environment, because you have to rely not just on healthcare workers in the NHS, but different people that are available. Some from the military, some who came back to work, for example, who've been asked to come back or who requested to come back and go on the GMC register. Suddenly you have to train people to manage ventilators, etc., manage it as quickly your patients. So you imagine all that. I think one of the things we've learned is that obviously it took longer than we imagined, first of all, and obviously we put lots of protocols in place. Ultimately, it came down to a few issues. One was, of course, the pandemic was managed well by the existing NHS framework by expanding by 100% the ITU capacity. And with the lockdown measures and the government policies, we managed to avoid the worry that we had about the surge to Nightingale. So ultimately, we didn't have that many patients in the end. But what it showed me was that if the necessity came along, we could do this, work together, both public and private partnerships, Ben, which is crucial, which I think is a change that we've seen now. Before there's too many barriers in place, how other organizations like the military and civilian staff can work together to create this at pace. So we learned a lot about all the partnership, the stakeholders, how you make sure you mitigate risk, and how you create a system of healthcare that is effective. So what I experienced, and I'm sure we'll learn a lot from it when we go forward.
And you're famously involved in the sort of future hospital type concept, the digital hospital concept. I mean, during the setup of the Nightingale, what from your, maybe last decade of working on this future hospital idea, this digital hospital idea, did you sort of draw through? You talked about, records and training, and just give us a sense of maybe how all of that knowledge and that learning over those years sort of compiled into that critical period.
Sure. So yeah, it's good to be involved in that. Obviously, it's about connected healthcare, Ben, because of the fact that we want to do less face-to-face. That obviously had huge implications. Also, because we don't want to touch too many people and reduce the contact. That also, of course, changed the way we're going to be doing virtual things. So then we talk about remote monitoring. So patients could have been remotely monitored. There's telemedicine platforms for communication with the patient and also family. We're worried about the effects of critical illness and maybe even death during this problem, and how we connect with people, communicate so that telemedicine works better. Many of the telecom companies came in and worked with us on that principle. So we looked at this whole concept of the patient being different, more empowered, communicating different ways using either telemedicine or other connected devices, and this concept about remote monitoring. And if you extrapolate that a bit further into primary care, Ben, which is I think the real crux that's really changed rapidly, overnight they had to suddenly go to online. Of course, they're much more ready than we were in secondary practice because they already had set up in terms of telemedicine and triage, etc. And they call it total triage. So we saw that also now. If you look at the patients with chronic diseases, like diabetes, like chronic obstructive airway disease or asthma, for example, before the concept was about primary, secondary care, lots of appointments. Now that's all gone. It's all about remote monitoring, remote sensing, less appointments, less face-to-face. And suddenly it will save a huge burden of money for the healthcare service, but also allow patients to take control of their own healthcare, which we've been asking for a long time about patient empowerment. But the last thing I'd like to say about all of this is what we've seen is patients are far more tech savvy than we ever imagined. They are driving the change. We've been too paternalistic in healthcare, Ben, for hundreds of years. We know best, this is the right way to do things. Now we've got a patient voice. So actually, we want to be more remote. We can do this. We can support you. Listen to us. This is the journey. So I'm hoping that this is teaching us about the public-private partnership, patient engagement empowerment. So we create a healthcare service that's seamless and more community-based, which is where connected health should be heading towards, to prevention, to well-being, rather than the secondary care, which is quite expensive and sometimes too late.
The big thing I'm taking away from all of that is this real systems level thinking. How does everything come together to make that happen? The other experience I wondered if was playing a role in this needing to act in a very agile way was actually your work in quite resource challenged situations. I think you've worked in conflict zones. I wondered if you could talk about some of those experiences of working in those conflict zones, working in resource challenged situations, and how you make the best of what you've got to deliver the best possible outcomes, and how you bring those learnings back even into situations where you maybe have access to more resources.
That's a really good question, Ben, and I'll spend a few minutes talking about it. So look, over the last 3 or 4 years, I've been traveling to over 35 countries. Anyone who sees me on social media thinks I actually live on a plane. Not quite true, but I do come home occasionally. So I've been working with governments, with healthcare systems. I've been working with surgical colleges, training institutions, just to figure out how can we make healthcare more equitable. Yeah, how to make it more affordable learning from healthcare systems. So the good thing about it, if you go to a place like India or say Bangladesh, where I spend a lot of my time, also in China, these are big populations. They manage a large populations. When you go to China, a hospital will have 10,000 beds. So then think about it. In the morning, you may have over 10,000 appointments just for ophthalmology. And they manage, somehow they just make it efficient. So what's there to learn? So much to learn from other healthcare systems, managing big populations at the same kind of much different price level, and still the outcomes are pretty good. So a lot to learn from that perspective. When I'm working in conflict zones, so for the last 5 years, I've been working with the Ministry of Health in Palestine and also Medical Aid for Palestinians, which is a charitable organization. I was invited there to do a whole review of the surgical facilities and training for cancer across West Bank and Gaza. I wrote a plan of action, which will be a long-term plan for them, which is then implemented. I've been leading that journey for the last 5 years. I've been on about 10 or 12 visits now, training people, putting courses in, making them self-sufficient, overcome the barriers that they have, of course, because of geopolitical problems. And then now, as you say, we're creating a cancer training for them so that patients with cancer who can't leave can get the necessary expertise within the country. I've used ways of telementoring people remotely, even 2 or 3 years ago, saying this is the way we can train, teach, because if you can't leave the conflict zone, then we should bring it towards you. But by not traveling, which is expensive and time inefficient, by actually using remote monitoring devices. And now actually on Sunday, we've set up the first remote MDT. MDT stands for multidisciplinary team meeting. So cancer patients all need a bunch of specialists get together to decide the treatment, which is the best treatment available. So we're having the first remote MDT for colorectal cancer on Sunday, 10 o'clock. It's taken a few years to get to this point, but now we can actually support remotely. So all it's teaching me is that even in conflict zones and the people who are refugees, we can make that world a better place, Ben, by connecting them, helping, supporting them, and actually using these technologies in a way that I think was designed for, to, again, make healthcare more accessible and more equitable, which is all of our ambitions. And obviously now, those ambitions can be accelerated beyond any measure.
I love this idea of the multidisciplinary team finding a natural home finally in healthcare. I think, those of us that work in innovation, but maybe not in healthcare, appreciate the value of having that different perspective, different fields, different sectors, and actually really coming at the problem all together. And I think that's finding a real home, or has done over the last couple of decades in healthcare now. Yeah. And a real shift, I guess, from the traditional model of, one person really driving the outcome. So you've travelled a lot. I've done my research, and I have a feeling that there's somewhere that you went to that you weren't quite prepared for your first visit, and that was Bolivia. Could you maybe just share a bit about your experience of going to Bolivia for the first time?
So for people who want to see my whole Bolivian story, I did a Wired talk last year. So if you go and search me on Google and go to Wired, you'll see the Hospital of the Future, it's called, and my journey to South America, which is my first trip to South America. I warn you, it's an interesting story. I think Ben found it quite amusing, of course. So I was invited by the government and by a guy called, I forgot his name now. He invited me to go to Bolivia to go and think about designing and creating a future hospital. And the ambition was quite a big one. I'd not been there before. They invited me. I went there for my first trip, and it was overwhelming. This is a poor country, aiming high. I met Evo Morales, the president, of course. And we're thinking about how do we create something that's modern, that's new, that's time, that's going to be, I guess, future-proof for them. And their vision was, look, we don't want to think about other countries' problems. Let's design our own problems. How do we think about what we can do given our population, the geography, etc., and how do we go forward? So Martin Dockweiler was my partner in this. And so, yeah, we've got great visionaries. And what it showed me from a literally the poorest country in South America, with the poorest health outcomes, is thinking much bigger. Thinking, actually, what can we do to even sidestep or even leapfrog other countries in healthcare ambition? How do we connect? So we created a system where there was a new electronic health record, connecting things, there's remote monitoring, as we said before, bringing telemedicine at the beginning, etc. There's all the things that you design something around future-proofing. The infrastructure was really powerful. We had proper cabling in, really high-powered internet providers, etc., so that people connect really quickly and have the future-proofing around all the access points, etc., so they can build on. It wasn't done straight away. It was a part plan, a few years of bringing things in, experimenting, using it as a kind of a medical innovation lab, saying, look, let's bring things in safely, and try experimenting and pushing that boundary of healthcare, as well as providing safe and affordable care for the local population. So it's great ambition. The hospital's opening up later this year. I took a year sabbatical, so I've kind of finished that year now, and they're opening, and I'll support them remotely as I can. But it's just a great story and a great journey, and I feel privileged to have been asked to do this and also be involved with such wonderful set of human beings in South America.
Yeah, I mean, Shafi, you're really playing this down. I would encourage everyone listening to this webinar to find that wired video. It's an extraordinary story, not only of what was achieved by the Bolivian government, the team, and that hospital, but also of the hospitality that Shafi received, which was just mind-blowing. You have to find that clip to do justice to that. So from one continent to another, I think you're also an advisor to the Abu Dhabi government as well for digital transformation of health and innovation. I wonder if you could share some insight into the kind of work you're doing, and maybe perhaps reflect on some of the sort of digital strategy insights that we can all learn from. Many of the people on this webinar now will probably be wrestling with their own kind of digital strategy, digital transformation challenges. And often there's a lot of inspiration to be taken from other sectors. So maybe if you could share some of your insights around digital transformation and what that means in maybe human terms and workforce terms and so on.
Yeah, that's a really good question, Ben. I think it's essential. It's the essential part that we forget. It's the human workforce. It's how do you bring them, encourage them, and how do you bring innovation at the heart of an organization. Ben, from your company perspective, you're innovative. That's what you do for a living. Others don't have that same agenda. They don't actually spend enough time bringing innovation to the heart of every person's job, giving them time and making sure they're thinking creatively. All the things that human beings are very good at if given the opportunity. So the work in Abu Dhabi, for example, is interesting. Abu Dhabi obviously has a small population of between 2 and 3 million. It has 50 hospitals or 50 healthcare parts of the hospital that are connected through a central healthcare information exchange. So they get good data. They can use that data to predict and how they're going to manage their health population. So they're very forward thinking. It's a young population. We're in the Middle East, United Arab Emirates has very few people over the age of 55, for example. Yeah, most are quite young. So young, fit, healthy population who are tech savvy. So therefore, it's a great opportunity for them to reconsider how they want to push and drive. So what they've done is they want to go from an oil-based economy to a knowledge-based economy, which is the right opportunity for them. So they've created a Hub 71, first and foremost. Hub 71 is an innovation hub that Mubadala have funded to the tune of $6 billion to bring tech innovation into Abu Dhabi, to change the way they think about things. That's across all verticals, not just health, Ben. They're creating an AI university, the first one in the world, to promote AI and learning, for example. So they really think much bigger. So my role was there to help support that change, and I'm setting up a digital academy for them. So all healthcare workers would go through an academy of learning, said before at the beginning of this piece, to create the most nimble, flexible, and digitally literate workforce possible, because that's what we need to do. Drive them. So we'll use the Hub 71 for innovation. We'll get them to think about how we create ideas that might impact healthcare in the future, and to understand that digital technology and innovation lies at the heart of that organization. So we're creating this learning system for them, and also building a digital health kind of symposium, which can be world-class, bring all the world leaders together, including their own startups, etc., to start working on this promotion of innovation across the healthcare systems. And that's going to be a long-term plan for them. But, it's going to be an exciting opportunity for them, and of course, for me also.
Fabulous. I'd love to check in with Josh. I know we've thrown a huge amount at him. Josh, again, I don't know if you can hear us, but I would love to see where you've got to on your live sketch. And again, maybe just share a couple of the themes that have stood out for you as we've been talking.
Sure thing. Hi. Well, I'm very involved in trying to find an image for your digital transformation and this kind of online university. And it's interesting to hear about this transition in Abu Dhabi from oil to data and information as their drive of their economy, which just goes to show how big all of this stuff is, how big digital is. It envelops everything, and hopefully for the best. So yeah, inspiring again. I've just got to try and capture it all on this picture.
Well, good luck. I know we're throwing huge amounts at you. Thank you. Shafi, you are not just a surgeon, as if there is just a surgeon, but you're also the co-founder of an education platform, Virtual Medics, and a surgical training system, Medical Realities. I mean, we've, kind of bounced towards the kind of rationale, the reason, the inspiration for these things already a number of times. But I'd love you maybe to sort of crystallize the spark that kind of made you make the jump and start these initiatives. Maybe you could tell us a bit more about them.
So I think with these things, Ben, it's been the right time, the right place. And I think more than that, it's been very fortunate to have been exposed to technology. I think about 4 or 5 years ago, we've always been innovative in surgery. As you know, we're always looking for the next best thing, next best utility, etc. Surgery's always been innovative at their heart. But 5 years ago, what happened, of course, is this whole concept of the fourth industrial revolution, as you know, Ben. Technology was suddenly available, which wasn't there before. Computing power was there, availability technologies, VR and AR, which is coming in, and we're talking about this convergence of technology and brilliance. So that was the story. And with my education background, I was giving a talk, I remember, at a Google campus around the work I was doing, and I met somebody else interested in AR and VR who's at the forefront and one of the pioneers in this country. We decided that healthcare and education was the future. So we created a company called Medical Realities. And the idea was to bring immersive learning to healthcare workers around the world, mainly doctors, surgeons, and other healthcare workers. I think we're too ahead of our time 5 years ago. The world hadn't really caught up with us. But now, suddenly we see everyone's phoning me and saying, have you got any virtual learning systems? My students are not doing anything. And, the last 3 months, for example, Ben, most of my trainees in the hospital haven't done a single operation. Okay, they've been supporting COVID-19. They've been redistributed around the hospital. So their learning has been static. So imagine if we'd had all that virtual learning in place now. They could have done those operations virtually. They could practice, learn, and did different kind of things. So now we're seeing a huge interest in surgical learning, surgical training, but virtually. And it's accelerating, it's taken off. And also we're getting the evidence around it, showing that it's more effective than traditional methods of learning online. And it bridges the gap between actually going to the operating theatre and operating, and actually learning, doing the bookwork, whatever it is, that bit between where you want to learn, simulate operations, train yourself to get a certain standard and get certification on that and validation. So that'll shorten that whole framework, allowing you to be much more comfortable and make less mistakes, probably ultimately in the operating theatre, that you're much more ready for your role as a surgeon. So yeah, that's kind of what we're doing with immersive learning. We set up our COVID, actually a dedicated website in the last 4 weeks with my team. So we have all the resources of COVID for any health worker to come along with training videos, experiences, and we run a daily webinar, grand round we call them, global experts coming together to talk about different specialties and how they manage COVID-19 as a free learning resource. Yeah.
And something you referenced just then was that your students have kind of been focused on other things recently because of COVID, and I guess we all understand why. But just sort of thinking more broadly on that point, many people have had to put aspects of their lives on hold during COVID, but it's a sensitive topic. Appendicitis doesn't go away. Diseases like cancer don't go away at times like this, and I guess the cold reality is there's going to be a wave of repercussions for the mainstream healthcare system. What are these going to be, and how can we best prepare to tackle them head on? What are we going to see, and how are we going to tackle it?
That's a really good question. So yeah, so what we've seen so far, obviously that we've cancelled elective operations the last 2 months. Remember, we carry out about 50,000 elective operations per week, for example, right? So imagine how that's multiplying week by week. There's a huge deluge coming of people who need elective operations going forward. Where's the capacity? How do we create the capacity? How do we manage that? That's going to require some work. It might take a few years to actually overcome some of that. More importantly, what we're seeing as a cancer specialist, it's less cancer coming through the doors. We've seen between 2,000 and 5,000 less patients a month that have got cancer that haven't turned up to be seen or presented in any shape or form because of the fear and anxiety around COVID and the hospital changing its way it performs its diagnostics and things. So that is going to come back at some point. We have to manage a huge influx of patients along with huge tailback of elective operations. And that's going to require some amazing kind of redistribution of workers, etc., to make it work. And that, I'm sure, will mean the private hospitals, the private providers also work in conjunction with the NHS to provide that resource and capacity that's required. So, and also we've seen less heart attacks coming in, 50% of less heart attacks coming in. What's happened to those? Are they at home? Are they going to come at some point to us? We don't know. Appendicitis will be managed at home because people come in later because they want to come in. So we're seeing late diagnosis, late presentation. So the next few weeks, as lockdown is much better and less restrictions in place, we'll see more and more people coming into hospital. And I don't know how we're going to manage all that. There's obviously lots of planning going in place. And we have built more capacity. So it's a question of how that capacity is going to fulfill our obligations to our patients.
I love this idea of time compression, and I think, you know, it maybe sounds doom and gloom to have those sort of cases storing up, but I love the idea. You were talking about a sort of 3 to 5 year time compression with some of the technologies that have been brought forwards over the last sort of 5 or 6 months, and maybe hopefully those will, within those, maybe some of the answers to help pull us out of that. So I said earlier on, you've been on sabbatical for the last year. Somehow I have the sneaky impression that you haven't been sitting idle during that time. Could you give us a sense of maybe a couple of the things that you've been working on during that time?
Of course, so I'm running my tech companies, and I do a lot of advisory work for many companies. I do a lot of speaking engagements. And last year I spoke in 20 different countries, giving keynotes for various companies and working with companies to bring digital transformation into their workplace. I also went to Bolivia on and off to support their program, the hospital, which we mentioned earlier, the Abu Dhabi government work. I had to go back and forth there a few times. I'm writing a book, of course. The book that we're describing is helping any healthcare worker navigate this new language of digital change to make it more comfortable, etc. Initially, I wrote it has to change now because it's kind of almost become not relevant when you think about how we implement that change now, as well as talk about technologies and where we are going forward.
So you were talking about the future, and the future's just arrived, so we've got to kind of leapfrog again.
About what the next feature is, or more about implementation maybe, and examples now that are real that might be illustrating some of the technologies. And the last thing is I'm working with Vodafone. I've become the UK ambassador for Vodafone for 5G in healthcare, to think about how we connect healthcare, which has always been my ambition. I'm trying to help them navigate their portfolio and their work around connected healthcare in the future. So that's obviously where I am, and I've just come back 3 weeks ago to my clinical work into a part-time role, so I can help build life sciences with the hospital and help deliver some more of the digital strategies that we need to deliver.
And I mean, it sounds a sort of a strange thing maybe to ask, but where do you get your inspiration, your energy? Is it human? Is it technology? You know, where do you draw on for this passion?
So I guess it's difficult to understand to explain that properly, but I think there's a few things. One is about leaving a legacy, leaving impact. What is it you're here for? What's the, when you get a bit older, Ben, it's about philosophy. What do you want to be remembered for? What do you want to do with your time that you have on planet Earth? And as we get older and see the COVID pandemic, showing actually, you're mortal like anybody else. So what is the impact? How do you help people around the world? And the global health work I'm doing is a passion. I want to improve healthcare and education for anybody. Having come from Bangladesh when I was young to the UK, I still have feelings for the other parts of the world that don't have access to healthcare that I've been fortunate enough. So it's giving something back to society, giving back my knowledge and my expertise. And also the drive to innovate and make things better for people, right? I know the tech is amazing. How do I become the enabler? How do I force the change? It's going to take these enthusiasts as early adopters to push the boundary. And now we're seeing other people now coming to view. My view is it's a long journey for all of us, and I'm just one part of that. And it's about me using my expertise, my knowledge, my network, my thoughts to collaborate to make this world a fairer place. And that's always been my drive, of course.
Very cool. And you know, we talked a bit, we've touched on this idea of the hospital of the future. I mean, paint a picture. We're already seeing, I guess, more of the healthcare taking place in the home through some telemedicine and so on. What is it going to look like? What is the system going to look like? You know, what system are our children going to be, you know, adults and parents and grandparents in? If we could sort of paint a picture of a horizon that far ahead in the UK, which has its own sort of nuance as a healthcare system, and then more globally. And I do get a very strong sense, as we've talked about, this ability to be able to look across different healthcare systems, you know, whether it's the US system or other systems where again access to HCPs is very varied in lower resource settings.
So yeah, it's a great question. So if you look at the UK going forward, what we've seen is the complete disparity in care, from social care across primary care and across secondary care. And what I'll see in the future is much more a seamless approach, so that patients can actually access that system much easier and be more patient empowered. And of course, it's going to be data driven. Therefore, there'll be what's called precision medicine or personalized medicine. So it's relevant for each individual. And that's something I think we aspire to, but I think will be delivered. I think there'll be more care in the community. There'll be more interest and more resources going to social care, of course, as it has to. More about well-being, mental health, things that really haven't spent a lot of time being invested upon by any government. So I think that's kind of where we are in the future. It'll be connected, of course. We described that earlier, by being remote, being accessing healthcare immediately when they need it, using technology, or smartphone will be the obviously the touch point. Of course, it's learning about the global system. I think we'll have a much more global system. So one of the things about the pandemic we've learned, it's a global pandemic requiring global solutions. And I think it requires global data and global partnerships to make it work, right? That's kind of my learning. And I'm hoping what we've learned from here is that we haven't done it well in the countries. We've been disparate. We haven't listened to what other people have gone through, learning experiences from Ebola, from SARS, from other pandemics in the past. Now what we're seeing is actually maybe in the future, we will take that into context. The global situation will be much more at the forefront of people, investing enough time and resources to learn from those experiences. So I'm hoping what come out of this pandemic is a world that will share its resources, that will make healthcare available for more people. And I'm certainly seeing that as we go forward. And that's kind of learning that we have from that perspective. So yeah.
I love this idea of really one of the legacies of the pandemic being that actually the global healthcare system really does potentially come together for the first time. And actually, I love the reference you just made there to mental health as well. I think there's been a lot of discussion around the mental health implications of the current situation on people spending time alone, spending time away from loved ones, and so on. And I think it'd be wonderful to see how digital can provide a potential solution to that. Just before we wrap up, I'd love to return for the last time to Josh to see how his sketching has managed to capture our constantly evolving subject. Josh, any themes that have stood out of the last few minutes that we've talked about?
Absolutely, yes. I wish I could go back and start again and make something that all fits together in such a beautifully formed way as you've described. Now we've got to the end of the conversation, I can see how it all fits together. And yeah, it really, the message seems to be about the idea of global systems, global data, global healthcare, and working together all through the repercussions of being able to use data and technology.
Wonderful. Thank you very much, Josh, and from Live Illustration. Thank you for joining us and trying to keep pace with us during this session. Ladies and gentlemen, I'm sorry to say that our 1 hour with Professor Ahmed is up. Shafi, thank you for sharing such inspirational insight into your work and your vision of a more democratized, more accessible, more integrated global healthcare future.
Thank you so much.
A huge thank you to you all for joining us from so many different parts of the world. If you joined the webinar late or would like to enjoy Shafi's discussion again at a later date, a recording will be made available on the Global Innovation Forum YouTube channel over the next day or so. Please don't forget to sign up for more webinars in the GIF What's Next series. Coming up next is the frankly extraordinary magician Butzi. This gentleman literally made a coffee table hover in front of our very eyes at an event 2 years ago. Butzi will be in conversation with Merle Hoare from Kinear du Fort next Tuesday the 9th at 3 p.m. I'll be back on the 18th of June in conversation with legendary auto designer Frank Stephenson. Until next week, please look after each other, stay safe, stay healthy, and keep innovating. Thank you very much.